Buongiorno. Thank you for coming here today and listening to what we have to talk about in terms of comorbid disorders in young people with autism or adults with autism. Can you hear now? Yep. So I'm Rafaela. I'm part of the Centre for Developmental Psychiatry and Psychology at Monash University in Victoria, Australia. A psychologist, but also finishing my doctoral thesis currently and investigating depression in young people with autism, specifically looking at what depression looks like in this population, how to assess it and how to diagnose. So this is part of a larger project, the paper that I'm going to present today. The larger project is looking, like I said, at phenomenology and a diagnosis of depression, but also looking at the efficacy of different assessment methods as well as different screening tools. Also looking at the various psychosocial factors which may also be related to depression in people with autism. But today I want to focus specifically on the clinical aspects of the study and basically look at what depression does look like in this population, how we assessed it and how the diagnosis of depression was determined. And hopefully this will provide you with some clinically useful information about assessment and diagnosis of mood disturbance in young people with autism. Initially, I want to consider some existing research in the area, focusing on methods used in the current study to follow that, and also looking at the diagnostic procedures that we did use. I will then look at a sample of 50 individuals that the current study looked at, and towards the end present two different case studies, one of a high-functioning individual and one of an individual with intellectual disability, and looking at the symptom expression of depression in those two individuals. So within a clinical setting, what we see is that young people with autism appear to have a higher vulnerability for developing psychiatric disorders. So can you hear that? Is that okay? Yep. And though depression has actually been the most commonly described psychiatric disorder, unfortunately large population studies haven't been conducted to look at the phenomenology assessment and diagnoses. What we do see in existing studies is that do look at the occurrence of depression is focusing on the prevalence of depression rather than actually the assessment and diagnostic methods that have been used. And what we see is a high variability in results, and the variability can be, explained in some ways by the differing in sample sizes. There's also been a lot of case studies that are part of that research. And also the type of sample used. So in a variety of different larger scale studies, it was a mixture of people with Asperger's syndrome, with a PDD, NOS, and also with high functioning autism, or individuals with an intellectual disability and autism. But I think the most significant limitation that we do see in the literature, and one that can probably explain the high variability as well, is the different diagnostic criteria that have been used. So in various studies we have criteria or screening methods used for individuals that are typically developing and looking at psychopathology, or looking at those particular screening instruments that are designed for people that are typically developing and altering it. Some authors have also designed their own diagnostic criteria for depression, although unfortunately in many cases it wasn't actually specified as to what criteria they used. So the focus again was on the comorbidity of depression in autism and the prevalence of that. Now, I think one of the things that's lacking in the research, and one of the reasons why it's difficult to have a diagnostic criteria or consistent diagnostic criteria is because there's a lack in valid and reliable tools to screen for depression in people with autism. So we need to sort of take a step back, I think, and start looking at the actual symptom profile of depression before we're actually able to do that. Yes, so one of the things that we wanted to do was look at a diagnostic criteria which was considered the gold standard, which is the DSM. And I think an accurate and reliable description of the depressive symptomatology in autism is really contingent on the consistent application of reliable and valid diagnostic criteria. And I think this kind of research can then lead to the development of valid, reliable tools in autism, screening for depression in autism. I just want to outline the current demographics of the study. So the individuals were between the ages of 15 to 25 years old. Past research have shown an increased rate of depression in adolescence and early adulthood, so that was one of the reasons why we chose a particular age group. Participants had a pre-existing diagnosis of autism, and that's to say that they were at some point in childhood assessed by the centre with a multidisciplinary team, and the DSM-4 criteria for autism was used. Thank you. To establish the diagnosis of autism at that time. We also looked at the core features of autism at the time of the assessment and collected a developmental history. If we look at the sample a little bit closely, what you can see is that the gender distribution is consistent with what would be expected. So 82% were male and 18% were female. We also had a good distribution of people that were high functioning, so 50% were high functioning individuals and the other 50% had an intellectual disability. We used a semi-structured clinical interview designed to specifically look at psychopathological symptoms and also look at the specific aspects of the young person's psychological, social, emotional and behavioural functioning at the time of the assessment. The instrument has been validated and has also been adapted and revised to be used with those with an intellectual disability. And it's very consistent with the structure of a standard clinical interview that you would use in clinical practice. So what we did in the first instance was see the family and the young person together to gather information about the young person's current mental state. So we asked questions about any change of functioning from what would typically be seen in that young person and directly questioned until the parents reported no other symptoms or concerns that they had. We looked at family history, like I said before, developmental history, a medical history, and collected information about psychosocial information as well. The second part of the interview, we tried in most cases to see the young person or the individual on their own where possible, and where they had adequate communication skills we were able to inquire about their schooling or daily activities and particular worries that they may be having, feelings, fears or any other troubles or concerns which they may be experiencing. We also had a projective section to the actual interview or the protocol that we used, which included projective drawings and feeling thermometers. And again, that looked at anxieties, sadness and worries, as well as angry feelings. Now, we found that the projective measures were particularly useful in those individuals that had an intellectual disability and were unable to express how they were feeling in words. We also found that the projective measures were able to provide information about the person's thoughts and feelings that, again, they weren't able to express verbally. The protocol also included a clinical rated formulation and a diagnosis section as well. And Annalise touched upon the overlap between psychiatric disorders and autism, and I think that's one of the main difficulties of assessing for the presence of depression in individuals with autism. So there's a considerable overlap between the symptoms of autism and those that we would consider to be consistent with depression. So, for example, a social withdrawal. Sorry about that. In addition, people with autism also have communication and cognitive deficits, so the features of autism can often mask the presence of a mood disorder because the young person has difficulties conveying what they're actually feeling and what thoughts that they may be having. So what we did in the current study was particularly focused, like I said before, on changes in their baseline level of functioning. And what I mean by that is looking at changes of how the individual would usually be observed to behave or to function. So we did rely quite a lot on third-person information from the parents or the carers. So what we did was use the DSM-4 TR diagnostic criteria to determine the presence of depression, but we also provided an equivalent ICD-10 diagnosis. However, what we also did was use complementary nosologies, so the ICD-10 guide for intellectual disability, the DCLD, and the Diagnostic Manual for Intellectual Disability, which is complementary to the DSM and takes into account atypical features of depression in people with an intellectual disability. Now, a consensus diagnostic approach was also used. So with the people that presented with clinically significant symptoms, they were presented at a case conference, which included either a child psychiatrist and a psychologist, or 2 psychologists, and the symptoms were discussed at length, and a diagnosis was agreed upon. If you look at the pie chart here, it just gives a representation of the percentages of the type of comorbid psychiatric disorders that we did see in the sample of 50 individuals. What we do see from the pie chart is that 60% of those are presented with a comorbid psychiatric disorder. 28 had a diagnosis of at least 2 other Axis 2 disorders, and I think it's important to highlight here that it's on top of the autism, so they've got autism and 2 other Axis 1 disorders. What you can see here is that 32% met criteria for a mood disturbance or a mood disorder, and what we included in that group is major depressive disorders or episodes, a dysthymia or bipolar disorder, most recent episode depressed, so they've been included in that 32%. And what we can see as well is that the high percentage of anxiety disorders that are also present in this sample at 22%.